Each year, millions of adults in the U.S. are diagnosed with vascular disease. And it's no wonder. With over 60,000 miles of intricate arteries and veins throughout the human body, there are bound to be complications due to blockages, weakening of the blood vessel wall, and other issues impacting the circulatory system. With an aging population and the growing incidence of risk factors such as diabetes, high blood pressure, obesity, smoking, and the disproportionate incidence of vascular disease in our minority populations, the management of vascular health is becoming a key focus among today's healthcare leaders and providers. As with any medical disease or condition, it takes an entire team of dedicated professionals to find new ways to efficiently diagnose and treat patients, as well as to improve their long-term care. In vascular health, the leader of the team is today's vascular surgeon. Only vascular surgeons dedicate their entire training and practice to address the full spectrum of vascular health, as well as provide comprehensive care that includes preventive, medical, surgical, and minimally invasive solutions. Through ongoing education and research, as well as pioneering new techniques, vascular surgeons are on the leading edge of clinical breakthroughs that are transforming vascular health. As part of their comprehensive approach, vascular surgeons partner with other healthcare professionals to provide quality care tailored to each patient. This patient-centered model is vital to help all physicians manage vascular health in at-risk populations and promote healthier lifestyles in the future. Vascular surgeons are involved in every part of the disease process, from making the diagnosis to the management of disease. Vascular surgeons are comprehensive leaders in vascular health. Today's vascular surgeons are creating a new chapter in the vascular health story with improved patient care, better outcomes, collaboration, and leadership. Surgery is only part of our story.
Welcome to our live webcast, an afternoon with SVS Wellness Task Force. We're joined today by Dr. Kim Hodgson, President of the SVS. At this time, I'd like to turn the microphone over to Dr. Hodgson for opening remarks and panelist introduction. Dr. Hodgson, the floor is yours.
Thank you very much, and good afternoon to everyone joining us today on another in the SVS COVID-19 Town Hall series, this time devoted to an afternoon of wellness with the SVS Wellness Task Force. I'm joined today by my co-moderator, Sam Money, who's a distinguished fellow of the Society for Vascular Surgery and chair of the Department of Surgery at Ochsner Medical Institutions, where he also serves as the Associate Medical Director of Surgery. Sam is also the current treasurer of the Society for Vascular Surgery. Before I move on with the rest of the panel introductions, let me just briefly recap last week's panel, which was on how is industry going to restart clinical support. So some take-home points from that were that vascular surgeons are reporting patients are delaying care for fear of COVID-19. Hospitals are limiting support specialist presence to higher complexity cases. Many vascular surgeons are uncomfortable sizing and performing on IFU EVAR. Most vascular surgeons would be uncomfortable performing an unsupported REVAR. And we've seen impressive advances in simulation, virtual content delivery, and case support. But everybody at this point in time is kind of looking for the sweet spot for teleeducation versus face-to-face learning and networking. So that's hopefully what we're going to be figuring out over the next several months. Before I return to today's panel, let me just give you a brief preview of coming attractions. Next week's town hall will in fact be that, a preview of coming attractions on SVS Online. We have a distinguished panel there. We're going to be talking about a number of things, including our first ever virtual SVS business meeting, our first ever virtual election of SVS officers, and if the bylaws pass, voting will be open to all qualified SVS members. So just to recap, we're trying to message this loud and clear everywhere we can. There are 2 sessions to this first virtual SVS business meeting. Session 1 on June 15th is primarily devoted to the bylaws amendment. We'll also be announcing the SVS Foundation Award winners, and the nominating committee will be announcing their officer candidates, and then internet voting will open. The second session will be on Saturday, June 20th, and will be our virtual business meeting where we'll have a brief state of the President's message from myself, reports from the Secretary and Treasurer, Foundation report, and ultimately then the announcement of the officers' election and succession of leadership. Once we're done with SVS Online, sometime, date yet to be determined, probably in July or so. We're going to be bringing Joe Mills in to talk to us about putting the new SVS branding toolkit to use and understanding your value to your hospital. Several initiatives at the SVS for the last year or so. And new on the horizon, date and panel not yet announced, is a town hall on the financial implications of upcoming payment reform. So with that said, let me return to today's panel and complete our introductions. We're lucky to be joined here today by Dawn Coleman, a distinguished fellow of the Society for Vascular Surgery, and the Handelman Research Professor and co-director of Pediatric Renal Vascular Hypertension Center at the University of Michigan Department of Surgery. She also serves as program director of the Integrated Vascular Surgery Residency and Fellowship at the University of Michigan. Next panelist, Shireen Shaloub, is the Associate Professor of Surgery and the Director of the Multidisciplinary Vascular Genetics Clinic at the University of Washington School of Medicine. Our next panelist, Malachi Sheehan, is the Claude Craig Head Jr. Professor and Chair of the Division of Vascular and Endovascular Surgery at Louisiana State University. And to give us an international perspective, we're joined by Purka Vakatma, who's the Adjunct Professor of Vascular Surgery, the head of the section of emergency vascular surgery at Helsinki University Hospital. He's also the treasurer of the European Society for Vascular Surgery and vice president of the Finnish Society of Surgery. So I'm going to unshare my screen at this point and reflect this over to my co-moderator, Sam Money, who will take it from here and lead off with some opening introductory comments and introduce our speakers. I will be sending out poll questions, which you'll see to the right-hand side of your screen. If you're not seeing them, you may need to exit full screen mode. You can answer those poll questions. And by all means, also, we're very interested in text-to-screen questions, or what's known as the audience Q&A questions. So please start those coming in so we can answer your questions. So at this point, Sam, I'll go ahead and turn it over to you.
Thank you, Kim. Great. Kim, thank you very much. Thank you for those kind introductions. I'd like to spend a few minutes introducing the problem and getting this meeting off to a start. I want to thank all of our contributors, and I also would like to welcome everybody who's viewing. I'd like to just tell you again that there'll be polling questions that'll be the right side of your viewing screen. And you can't be in full screen mode to see them, but you can respond to them and you can pose questions and chat with us. Let's just sort of look at a little bit of a background here. So let's look at the surgical personality. Clearly, we're goal-oriented. We are type A, and we need achievement. Our ego function is based on achievement. That's just what we are, being surgeons. We're high achievers, and this is from a older Harvard Business School review article, and it talks about high achievers, and that's what we are. We're driven to get results. We're doers. We're highly motivated. We crave the positive feedback of doing that case. We are competitive. We're passionate about our work, and we're independent about it. The thing is that the COVID pandemic has changed a lot of these drivers for us. We're not doing a lot of these cases. We're not getting that positive feedback. We're still passionate about our work, but for most of us, our workload went down significantly. So let's talk a little bit about diminished wellness. And I found this in an article, and it said, there are things I can control, but the things I cannot control. And unfortunately, the things I cannot control seem to bother me more than the things I can control. And I'm going to share a little vignette of one of my colleagues. He was absolutely terrorized by the thought that he may run out of toilet paper at some point. So he went to 4 different stores and stockpiled 48 rolls of toilet paper for he and his 25-year-old son. He could not control the fact that there might not be enough toilet paper. So for 2 days, he was compulsive, going to store after store. Do you think he had a little bit of anxiety about this situation? So what other situations did we not control that caused us stress? The media reports, basically you can't avoid them. In March and April, beginning of May, depending on where you were. The overwhelming reports were on COVID and the problems with COVID. And then the medical centers changed everything. Elective cases stopped. The medical centers hunkered down. We built more ICU beds. We recruited everybody. In my hospital, we had orthopedic surgeons taking call in the ICU next to a critical care surgeon. We brought everybody in. Caseloads were reduced tremendously. And then we got hit with what's going to happen with the finances of the hospital. And I think Dawn's going to touch on this a little later. And then there was the lockdown at home. You know, what do you do if you're stuck at home for a week or 2 weeks, or in some cases, non-physicians but family members are basically locked down for 6 or 7 weeks at home? Social distancing is a problem. And then what if you called in to cover an ICU or to cover a floor with COVID patients, or to have to do procedures on someone with an ischemic leg because they have COVID-19? These are all issues that we face that diminish wellness. Before all this started, these are some of the numbers from our survey. Basically, the average vascular surgeon in North America works 63 hours a week. I doubt they were working that much now. They were on call 2.7 days a week. Probably during COVID, they may have been on call, but it was doing different things and not being called as much. At baseline, we had diminished wellness compared to the general public. This is just a burnout slide. Physicians burnout averages in the mid to low 40s. The general population is about 26%. So just baseline physicians have diminished wellness and a higher rate of burnout compared to the general population. That's baseline. That's before COVID hit. What did we find in that study? 1 in 3 surgeons, vascular surgeons, reported burnout on their own. 3 out of 10 had emotional exhaustion. An additional 10% had depersonalization. Overall, 41% had burnout. And this will be discussed a little more in depth later. I love this slide because it really summarizes it. Asking a significant, almost 1,000 vascular surgeons during the past month, have I been bothered by feeling down or depressed? These are pre-COVID numbers. More than a third have said they have. Suicide ideations, well, we may not be Sweden or Finland, but approximately 8% of vascular surgeons said yes, they had suicide ideations, significantly higher than the general population. And this is the most striking slide for me. The rate of alcoholism in surgeons is about 1 in 7, but yet in female surgeons, it's 1 in 4. Did COVID make it worse? Are there other issues? We'll see a little bit more about this in one of our talks this afternoon. So there's no obvious data on pandemics. There aren't a lot of pandemics where we have good data on, but based on natural and environmental disasters, we know that there's increased depression, there's increased PTSD, clearly increased substance abuse. It's interesting, by the way, when a hurricane is going to hit, what does Walmart bring in? Cigarettes, batteries, and beer, because they know that's what's going to sell out. There's increased spousal abuse, and there's increased child abuse, unfortunately, for all of these. So as Fred Weaver in the USC group has called us, we're the firefighters of the OR. We're the firefighters of the hospital. We run to the fire. However, there are a host of articles about natural disasters and its effect on firefighters. Increased amount of depression and post-traumatic stress syndrome in firefighters. Well, we are the firefighters of the OR. We'll spend some time today discussing some of these issues and its effect on vascular surgeons. With that being said, I'd like to introduce our first speaker, unless there are some questions. Kim, do you have any questions coming across at this point?
Why don't we go ahead to your first speaker? You'll have to unshare your screen for her to share hers.
It's my pleasure to introduce our first speaker, and she's been introduced before. Shireen Shaloub is a associate professor of Surgery at the University of Washington. She also has an MPH in epidemiology, which at this point has become more valuable than just about anything else we've heard about. So without further ado, Shalhoub, will you educate us a little bit on what's going on?
Thank you, Dr. Money and Dr. Hodgson, and I hope you can see my slides. It's truly a pleasure to be here and to share some of this information that we gleaned from the SVS Wellness Task Force Pandemic Practice Anxiety Coping and Support Survey for Vascular Surgeon. For the audience, just by way of background, as Dr. Money has outlined, the COVID-19 pandemic has affected us quite tremendously. And early on in March, when this started sweeping the country, there was a lot of peer support that started forming via SVS Connect, as well as Surgeon Masters, and then through the Vascular Surgery COVID-19 Collaborative via the WhatsApp chat that was created by Max Wollauer. And the teams became very clear that we were experiencing something collectively in very similar manners. And part of that discussion, we said, well, we wanted to help our colleagues cope with what we are all experiencing. And to do this, we have to do this scientifically. So we decided to examine the impact of COVID-19 on vascular surgeons and explore the COVID-related stressors, as well as coping strategies and support structures. So the way we did this is via an anonymous cross-sectional global survey. We incorporated two validated measures. One is the General Anxiety Disorder 7-item GAT-7 scale, and then the other one was the Brief Coping Orientation to Problems Experienced, or Brief COPE for short. We also asked about how this impacted their practices and what the related stressors are, so I will share with you some of that data. We disseminated the survey over a 10-day period, and it was driven by the Society for Vascular Surgery email list and communications, but also was amplified by a bunch of other organizations, including the Association for Program Directors in Vascular Surgery, the Vascular Frequency Disease Consortium, the VASC-C, as well as in Brazil. We've published articles on it in Vascular Specialists and via Audible Bleeding. And really, it's a very long list of people who amplified the message to say that this survey was happening. And within the 10 days, we received over 1,600 unique responses from 58 countries around the world. And you can see here the global map and the map of the United States. The darker colors are the more responses that we received. We received an overwhelming response from the United States, which was close to 700 respondents, and then nearly 500 respondents from Brazil, and then Mexico were over 100 respondents. We had 71% were male and 29% were female. So here is the distribution of the practices. So you can see that we had 15% trainees, and then near even distribution by decade of practice post-graduation. You can also see that around 34% were academic and a little bit more Veterans Affairs employees, and so you can see there was an overlap between these groups. But then also across the board, we had community surgeons, multi-specialty clinic surgeons, solos, and people in outpatient practices only. So what did we learn from the data? Here are the 7 items that are asked about in the GAT-7 survey, and you can see, for example, by color, the orange or the darker color these are the worries of every day, and then it goes less frequency over half days and several days, and this is asking people about how they experienced this over the last 2 weeks. So you can see that feeling afraid as if something awful might happen was very common as an experience, and that makes sense. Again, we were all experiencing this new phenomenon that we didn't know how it would end or how it would proceed. But also you can see that being irritable or having trouble relaxing or not being able to stop worrying was also fairly common. And the way this scale is scored is then based on the way you respond, you have a cumulative score, as you can see here, 0 to 21. And you can see that the majority, thankfully, had no anxiety or mild anxiety. And so that makes sense in terms of the surgeons group being a resilient group. But you can also see that 1 in 4 experience moderate to severe anxiety. And so that, again, is fairly significant. We asked about how people were reacting both on a personal level, how COVID impacted them personally, as well as occupationally. And so you can see here that a very common worry, with almost over 90% had at least found this somewhat stressful, was worrying about their family and friends getting infected. We also asked childcare responsibility and home cleaning and empty shelves in grocery stores, the toilet paper phenomenon that was happening at that time, and you can see that that also led to at least being somewhat stressful in the majority of people. We also asked about domestic violence, and thankfully the numbers were small, but certainly not zero. This was of interest here. There was a lot of discussion on the support groups about how to alter your home routine when you get home from work and you've been exposed to COVID-19. And you can see that a minority of people on the top here had no change really in their practice, or at least at home. But the majority of people had a separate changing area at home, but were still using the shared spaces. And then some people were staying self-quarantining in a separate room at home or staying at the hospital. And what was interesting is we took this and tabulated it against the degree of anxiety, with severe anxiety again being the orange and then some anxiety being the white. But you can see that there was a stepwise increase in the level of self-reported anxiety associated with these changes in home practices. So the people who were having to variate from their home routine were more likely to report higher anxiety levels. We also asked about whether or not people were using social media or they found other resources useful. So most hospitals had some sort of town hall. This is the column in the middle, so you can see over 50% found that useful. And then you can see social media, Facebook, LinkedIn, and Twitter had a lower number of followers. But really, SVS Connect, WhatsApp, and Zoom were very popular, and Zoom certainly has exploded in its popularity during this time where everybody has become much more comfortable using that. This one here, and this ties in very well with the previous work that the task force has done. But you can see that, about in this column here, 1 in 3 people have discussed dying with their family and their friends, and certainly smaller numbers have reviewed their wills or reassigned their power of attorney. We also wanted to know if they were aware of wellness resources, and around 50% were aware of the SVS physician wellness programs. So that was encouraging. But you can also see, talking about the suicide prevention, so about over 10%, close to 13%, were aware of the suicide prevention lifeline at that time. Other worries, these are the occupational worries. You can see that, again, the worry about people getting infected with COVID-19 was very high among the vascular surgeons. Certainly, information overload was very stressful. So this is asking them how stressful this experience was for them. So very stressful. Again, the darker colors all the way to the white, which is somewhat stressful. Impact on career advancement was prevalent as well, and that was more prevalent among trainees or junior faculty. Lack of PPE was a stressful event, as well as worrying about adverse events due to the care delay to our own patients. People were definitely concerned about that, as well as terminating contracts of employees. It's worthwhile to talk a little bit about financial concerns. So again, this is the scale of whether or not they found it very stressful in the dark orange, and then white being somewhat stressful. And you can see that the majority of people had experienced financial concerns as being at least somewhat stressful, if not very stressful. And people in solo or outpatient practices only definitely found that to be a stressful event for them. Here is the results of the COPE survey. So this is that brief COPE survey that I mentioned. And you can see that this one scores them as active coping strategies or avoidant coping strategies, as well as with questions about religion and humor use, which are considered neither active nor avoidant. And what you take away from this is that active coping strategies are predominantly the way we as vascular surgeons cope with the world and with stresses. We are action-oriented, as you mentioned, and we also use emotional and instrumental support. We practice positive reframing. This is the glass half full or the silver lining of the situation, as well as planning and acceptance. But we also use, in the avoidant coping strategies, we use self-distraction quite a bit. This one falls under 2 questions. One is, did we self-distract by work? And I would argue that doing this survey was an example of self-distracting by work. And also the other one was passive activities such as watching TV or reading books. And as evident by Netflix stock soaring during this time, I mean, you can see that this was a common coping strategy. The religion differences was interesting looking at regions. For example, when we compared the United States to Brazil, Brazil had much more religion coping strategies compared to the United States. So there's definitely some regional variations. But in general, vascular surgeons are an active coping type group. When you look at the multivariable analysis, you'll see here we again wanted to know how do these things associate with increasing degrees of self-reported anxiety. And so the genders turn out to be significant. This is not surprising because in general, we know that women are more likely to self-report higher anxiety levels. But what about the other things? So the home routine was definitely significant, and so were work-related stressors like donning and doffing PPE, worrying about adverse events for their patients, and financial concerns. And then, using coping strategies also correlated as well. And 2 points to point out is one, that positive reframing, people who use positive reframing, the silver lining approach, had reported lower levels of self-reported anxiety. And then the summative hospital support is worth mentioning a lot, because this is ultimately how we as institutions or societies can support our vascular surgeons. This included things like present of adequate PPE, preoperative testing for COVID-19, having opportunities to interact with leadership, having leadership that is transparent in how they're managing COVID-19, and having operating room protocols. So having these support structures in place were associated with lower degrees of self-reported anxiety. So what we've learned is, again, what we expected is to see that there was stress, but definitely there was a lot of worry about patients' care delay, worrying about friends and family and colleagues being infected, as well as the changes in the home routines, and I showed you the financial concerns. Definitely hospital support was associated with lower self-reported anxiety levels, and this is a golden opportunity to help support our working force. And I will leave you on an up note. This is a word cloud, and it summarizes it's a summary of the most frequently mentioned words in the free text responses that people filled out. And it was very heartwarming to see that patients really remained at the center of what people were worried about. It was quite striking. I had chills when I saw this at first glance, and you can see COVID-19, of course, was a big player. And so with that, I do want to acknowledge everybody that worked really hard and used this coping mechanism during that time to come up with something useful for our colleagues and all the groups that amplified these messages. And again, I thank you for the opportunity to share this data with our community.
Shireen, that was a superb talk, and it really sort of put things in perspective. I have to say that just one thing that struck me, people did not like getting too much information. I wouldn't let that out to hospital administration too quickly.
Well, I think it was mostly just the information overload, and it was a general question about information overload, and I would argue that the news cycle nonstop talking about COVID-19, plus all the overwhelming information, so you do have to unplug once in a while to control the stream of information. So I don't think that people don't like too much information, I just think that there's a lot of information related to COVID-19 coming all rapidly. And I think that's what's stressful, in my opinion. That's my interpretation.
Great. The other thing is, aside from Netflix stock doubling, Peloton stock doubled also. So a lot of people are going to have new places to hang their clothes to dry in 3 months when this is all over. Kim, do we have some poll questions?
Ronnie, can you go ahead, Blue Sky production people, if you can put up our poll questions? We got 3 answered. Just give us a little feel for where our audience is today. I'll start with I'll read the first question until they can come up. Here we go. All right. And I guess I have to reveal these. All right, so this is the response we got from this question. So I would imagine that this changes somewhat depending upon your local environment and the COVID penetration there. Maybe I'd ask someone like Shireen or Sam, who's been living in places where you've had a heavy penetration. Do you stay in a separate facilities from the rest of your family? How would your answers compare to that? I
have not implemented any changes other than just a place to change. It's really in the beginning, but now I've stopped doing that. I can tell you that when we looked at regional variation in the response to the survey, the Northeast had the highest impact, and that makes sense, right? Because they had the highest numbers.
Right, and I have to admit that I live alone and bought too big a house, so I go to any room I want whenever I want.
What about you, Mal? Things are pretty hot in New Orleans. You're muted at the moment.
Unmuted. Yeah, my wife and I are both vascular surgeons, so we kind of instituted a home scrub, work scrub policy, so there are different piles at home, and just so things don't get too confusing. But we do, obviously we stay with the kids and everything, but we try to kind of anything that we wore at the hospital, especially during COVID procedures, just stayed there and didn't come home. So we kind of wear scrubs from home, change at the hospital to the hospital scrubs, change back in our home scrubs and come home.
Have you had to do anything, Pirkka, in Finland about worrying about bringing stuff home?
Well, obviously, yes. But I think the system is a bit different. I take my own clothes to the hospital locker room, and there's good facilities for shower, and take the hospital clothes from there. They're washed in the central laundry, so I would not go in my scrubs home anyway. But many people take a shower after their work and so forth. So yes, there are some changes, but we do live with the families. I don't know of anyone who would have moved to a hotel or a second room or so. Actually, we have 6 kids from 14 to 21, and the 21-year-old guy just his friends got COVID on Sunday, and now he's cohorted, and we are at our country place. So let's see what happens. But yeah, it's coming to your skin anyway.
Dawn, did you have anything you wanted to add to that, your routine?
Oh, not a bit to add. It's in line, I think, with most of the comments. Thanks.
All right. So here's our second poll question. Give you a feel as to where the audience is at here. Shireen, this was a question you submitted. I guess this is a standard wellness format. Doing it a lot, doing it a little bit, whatever. So this is kind of interesting.
Yeah, this is from the COPE survey. So this was the distraction question that I had mentioned, whether you're taking your mind off of work. And there was another question about the, like the Netflix kind of things.
Yep. Any of this surprise anybody? All right.
Not really. Not really. We have problems at home because my wife is an anesthesiologist, and she's been running how to upgrade the intensive care units and the personnel there. So we talk a lot about work at home. So I took up a running program. That may be a thing here.
All right. Well, here's the third poll question that was answered about substance abuse to make yourself feel better. I'm not sure we have 0 admitting to doing it a lot. Maybe they're still asleep. Oh, they just woke up. This is a big concern. I must admit, I'm not the wellness expert in this panel by any stretch of the imagination. I'd be interested in feedback from the wellness team about this.
Dawn?
Well, I think this gets to the coping strategies that Shireen presented earlier. And this would be an unhealthy coping mechanism, but I will say that I have heard this expressed by friends and colleagues and peers, not in an insignificant way. So I believe this. And I think people are kind of actively working through the phases of COVID, and we've moved from this immediate crisis response to a more kind of sustained pivot where we're trying to understand what the next steps look like with this evolving new normal. And so I anticipate even this data is going to kind of ebb and flow as we move through this together.
Yeah, I was going to say, I
sorry.
wonder if this is a response more to inactivity than to stress in this circumstance. People who are used to being on call all the time, emergencies coming in, got to get up early, now all of a sudden are sitting at home. And I think there's some of that. I don't think this is solely a stress response right now. So hopefully, as people get back to work, this trend reverses.
I agree.
I will say that socially it's been interesting because if you see on the news, places that sell alcohol were deemed essential businesses. So, I mean, it tells you that at least nationally, it's still viewed as a coping mechanism.
Yeah.
I think the key to this question is how one defines a little bit of drinking versus a medium amount of drinking. And, I think people who have 1 or 2 glasses of wine every night and suddenly go to 3 to 4, well, is that a little bit of drinking or is that a medium amount of drinking? So this is sort of beauty is in the eye of the beholder. But as Shireen just pointed out, This is an essential business.
Mm.
The fact that Walmart sends in more beer before a hurricane says a lot.
So I'll tell you, in Springfield, Illinois legalized marijuana a year or so ago, mostly to try and get us out of our budget deficit. And there's a never-ending line outside the dispensary for that's for sure. It is a common coping mechanism. I guess it's considered an essential business in Illinois to get us out of our tax issues. So, well, we've got some text-to-screen questions, but I think several of them are already going to be answered by subsequent speakers. So it may make sense just to go ahead and kick it over back to you, Sam, to introduce your next speaker.
Thank you very much, Kim. Our next speaker comes to us from, I guess, his country house outside of Helsinki. He is an adjunct professor of vascular surgery at the University of Helsinki, and he's also vice president of the Finnish Surgical Society and treasurer of the European Society of Vascular Surgery. He's done a fair amount of work on wellness in the European vascular surgeons. So we thought it would be really helpful just to get a global view. So it's my pleasure to introduce you all to Prika Vakatma, who hopefully I pronounce his name close to correctly. So thank you, Prika.
Thank you, Sam, for the nice introduction, and greetings from Helsinki. It's about 8:30 here, or it's not actually Helsinki. We're 120 kilometers away, drove here after work, and trying to cope with the isolation of COVID, obviously, at the country place for some nights now. I'm honored to be sharing this evening with you, with SVS and about wellness. I cannot give you a global view on wellness, obviously, but just a small part of Northern Europe. So I this time focus on the Finnish, what's been happening here. I take it you have not been very eagerly looking at how the Finns are doing, so maybe greetings from the other side. Here, sorry. No major conflicts of interest. The societies came already. We're supposed to be very happy in Finland. We are the 3rd year running, beat the others in happiness, whatever that means in the World Survey. And I don't think that's very wrong. I think we have a good system, and there may be better systems, but the people are trusting the others. We think we are trusting our leadership. We have a safe environment, and the social support network works pretty well. So I would say this is partly true. The other side of the coin is that we used to have a lot of suicides in Finland. Actually, they went down since the high rates in 90s, primarily male suicides, with a gradual drop to the levels of other European countries. As you see there in the Eurostat from 2018, we are a middle suicide country nowadays. But this has been seen now as an increase of 15% during the current crisis. One issue that was not discussed so much yet, I could say that the COVID is actually bringing the world together, because Shireen's talk sounded like it could have been a talk from a Finnish doctor. So I don't see the coping systems or anything very different. Different countries, of course, had to jump very quickly into this digital meeting culture and teaching of children and everything. And I think we were quite lucky in Sweden, Finland, Denmark to be on top of this a bit perhaps before others. There's a lot of European countries where I travel, and I get very annoyed that the IT lines are not working and so forth. Now I'm sitting in the middle of the woods, and I have a full 4G Wi-Fi for you functioning. So it's actually working in practice as well. The timeline for COVID was something like this. So in the mid-March, the decisions were made to close down the schools. the gathering restrictions, but we were never actually locked down at homes. We could go to shops, we could go out. There were no police outside in the streets as there were in Spain and Italy. The restaurants are still closed. They are they are supposed to open next week with terraces and restrictions. The amusement parks are to open with 20% of the people can get in from the normal. So we're getting back to normal. On the left side corner here, you can see the daily infection rate. These are from the Worldometer statistics, and actually the infection rate remains very low compared to the projected ones, and that's the infection. This, I think, in the middle is the interesting part where you can see where we are in the epidemics, and we are all actually in the downhill. Also in the US, Sweden had a very different strategy from the other Nordic countries, and that could be clearly seen during this first wave of the epidemic. It might be bad for us that we were so restrictive and closing up everything in the beginning when the second wave comes, but I haven't seen that the Swedes would have an immunity yet either. So we were quite lucky, and this of course adds to the trust into the things that people or the governance that people feel. Here is an important, from my hospital perspective, important slide that actually what we aimed with the lockdowns was obviously to protect the ICU beds and the hospital resources. And the great difference here is, as you see, Finland and Sweden are about the same size, or Sweden is about the double. They have 9-point-something million people, and we have 5.5 million people. This is not the totally accurate number. As you know, the Worldometrics has some uncertainties in their numbers, but you can see the proportion that Sweden had to lift their proportion ICU beds available for the COVID patients. So this is the available beds minus available beds for COVID minus historical use. So these are the extra beds. I had some email exchange with some money when this was all coming up, and the message that I got from you was that be prepared to get more ICU beds. That we did in Helsinki and elsewhere in Finland, and we actually never went up to the level that the ICUs would be full. So there are some uncertainties in these figures. But anyway, you can see actually even better in this, that is about the all beds, that the resources were never fully taken. So as you have been discussing, we experienced the same thing, that there was a lot of preparation, and then there was a lot of frustrated doctors who didn't do their normal jobs. Of course, a lot of ICU people doing a lot of work, but we had to cut down our activities. But hospital resources were never fully in use, and this increased actually the people trusting the governance system. As you may know, we have a multi-party system compared to your two-party system. And some of you might have seen, because it's been on a lot of Twitter and social media, that it's almost funny, our government, how young they are at the moment compared to the others. Luckily, we have a president who's a bit older, and he belongs to the risk group, but they have been coping quite well with the situation. So actually the numbers supporting the young 34-year-old female government leader, Sanna Marin, has been going up during the March quite substantially. So they've been doing the good job. I have a couple of slides regarding the ESVS fatigue survey we did together with you guys. Just two of them. And then I have from the Finnish Medical Association, the normal physical wellness survey that we do every now and then. And then some slides about the COVID situation. This ESVS survey is a bit old, a couple of years back. But and the 15% answering percentage is not excellent, and as you can see, it's a distribution from very different countries, so it's more variable than for example having it only from the states, from 52 states. So you cannot say that this would be a single country, but yes, in Europe, as in all over the world, the vascular surgeons do feel fatigue, burned out, 54% more than once a week, feel fatigue when they get up in the morning and face another day on the work, or 1/3 feel burned out. And this was the most alarming thing about our survey. The taking your life percentage was even higher than in your survey, Sam, that you did. The Finnish Medical Association regularly looks at the reasons why there are difficulties in working conditions, and this is a survey from 19. The experience why we do, and I think this is global with the big differences, the reasons why we feel discriminated at work. And what I'm actually quite happy about is that the color or race or political union or the sexual orientation are very low, low in the scale. What is maybe obvious is that the favorite systems, because it's a small country, because there's not so much competition, because people maybe are not so able to go anywhere. There we are more like we have one big hospital in Helsinki and everybody more or less has to work there kind of country. So the favorite systems are overrepresented here. Gender actually as the second one is surprisingly much, because we think that we are very equal in that one. Luckily, pregnancy doesn't seem to be very important. And this is a bit of a busy slide, but this is, I highlighted in red the ones that might be interesting. So this is a question: how often have these issues clearly disturbed, worried, or put strain on you during the last 6 months? And it's mostly healthy things like we are performers, so haste and unfinished tasks and so forth. We actually, with the COVID situation in my hospital, we were lucky because we were just about to get the EPIC, and so we cut down our activities to about 50%, and then we got COVID instead. So I don't know which was the worst one, but we were prepared already when the virus was coming in. So it was actually like 1 or 2 weeks into that situation. So our ORs and everybody was already prepared. So now the EPIC is coming in October if the COVID second wave is not hitting us too hard. And what is also remarkable, maybe a difference to some countries, is that our on-call system is not regarded to be very, very difficult. And also it may be different to the US, that dealing with complaints or lack of or the legal issues are not that important in Finland because of the system. The questionnaire to 8,500 members, answered by 8,500 members so these are less than 70-year-old physicians or doctors in Finland, not vascular surgeons. But as you can see, in 1 week, I think it was a quite nice answering percentage to a very simple, fast questionnaire. 30% of the doctors were working in COVID environments. 70% did not feel any lack of protective gear during their work, and only 5% actually did. So I think that preparedness was quite well, at least in April. At the moment, we do have enough protective gear, and there was a Finnish factory starting to make 1.5 million something in 1 week. I mean, FFP3 mask, which would be enough to be self-sufficient in the second wave. The testing, they did get to test if they wanted to, and got enough information. So the reflection about did you get too much information was not seen here. And in hospitals, the answerers did not feel that the amount of doctors would have been a problem. As you know, we were a bit rolling thumbs as well. So this is 2 charts from my hospital, Friday 3rd of April and Friday 29th of May. So that's this morning. So you can see that the COVID situation This is the 19 operation theaters plus the couple of rows here. So you can see the COVID situation took down the activity quite substantially. This is this morning, almost normal routines. We have 2 theaters, number 7 and 19, for isolation patients. So we in vascular surgery stopped venous surgery totally, and elective arterial surgery from 13 tables to 5 tables a week. So that was a substantial drop. We had clearly less also emergency patients. We have operated actually 0 COVID positive patients. We have operated 5 suspicions in isolation. So this has led to that our patients who come to the emergency room, they actually have a better access to urgent operations. We have more space, have had more space. The ward is now full, but we had more space on wards, more time for paperwork. Our ICU capacity has been okay, but having said that, we have not done almost any operations that would need post-operative ICU. I mean, elective ones. The queues were hit, but mostly the non-so-urgent queues. There's still legislation in Finland that if a patient waits in queue more than 6 months, the hospital gets an economical punishment, which has been actually now waived. So now I think it's 9 or 12 months at the moment, but we got 40 more patients to that queue. But actually the queue became shorter, which means that we were able, because there's no legislation that we need to operate the 60 millimeter aneurysms or whatever during 2 months or so. So for the more urgent ones, there's no legislation. So we have actually been operating more of those, and the total queue has not been becoming more. So we are now back to almost normal activity. The venos are to open in June, and the schools were open 2 weeks, and today was actually the day that the kids started again their summer vacations. So greetings once more from the European Society, and I'll invite you to a live month, 29th of September. So we're not going to Krakow this year, sorry for that, but we're going to have a live webinar session as well. Thank you very much.
Very good. That was great. I really appreciate it. Do I have questions from members of the panel? Anyone has one? If not, you know, I'm sort of struck by the Swedish experience. So they were going to go for herd immunity and take all the consequences of COVID early. According to what you've shown us, that did not work out well for them, did it?
No, not in the first wave, it seems. There is it's quite clear because Norway, Denmark, and Finland are about in the same policy, and Sweden has a totally different policy. And the figures for the other 3 countries are about similar, and Sweden is totally different. So Sweden actually has more COVID deaths per capita than the US. So no, it was not successful, and that's their chief epidemiologist, Anders Tegnell, has also admitted that they could not protect their old people. On the other hand, we of course, nobody knows when the second wave will hit and what will happen then. So we're still very careful to say that they were not successful, but that at the moment it seems so.
Well, I have to say that where I am, we were a hot spot, and 2 weeks ago or 3 weeks ago, we did antibody testing on everybody who works in the hospital. This includes doctors, surgeons, anesthesiologists, nurses, technicians, secretaries, and our antibody positive rate was about 8%. I'm wondering what it's going to end up being in Sweden. Has anyone, their hospitals also tested for antibodies across the board? Anyone on the panel?
We actually tested.
We're rolling it out, but haven't. I'm surprised the number is that low.
In Helsinki, we actually tested, and there was a bit of a risk group of 1,800 tests, and that was exactly the same, 8%. In Helsinki, which is the hotspot in Finland, in Helsinki University Hospital, we treated most of the COVID positive patients. Swedes have a figure, but that hasn't been shouted out loud, but it's quite low as well. So Stockholm region has a bit more than other regions, but they are nowhere near herd immunity.
So the Swedish experiment so far has failed, but if there are multiple waves, maybe they're right. Any other questions about?
Yeah, I have a quick one for Perka before we move on to the text-to-screen questions. You had mentioned that too much information didn't prove to be a stressor in your survey, yet it did appear to be a stressor in the Wellness Task Force survey. I'm wondering if it's too much information that's stressing us, or too much conflicting information that is stressing us. I'd be interested in the wellness panelists' thoughts about that. We have a lot of conflicting information here in the United States. You may not have it over there.
Yes, we do. We have a lot of conflicting US information as well. So it's all over the place. I don't know if I'm the right person to answer your question, or even if the question was to me, but yes, of course, there's everybody's fed up with reading the newspaper, but that's how it is at the moment.
I'll also add that I wonder, when we talk about too much information, what specifically that means. I'll suggest at an institutional level, transparency and knowledge can be really empowering to help people respond during a crisis. And so I felt like that was really urgently needed and given to us here in Michigan. And I'll suggest that when we think about the broader scale of information dissemination, not only is it sometimes conflicting, but it's been highly politicized with a very clear kind of partisan divide. I think it just exemplifies how much unrest we're feeling as a country, and I don't think that feels good to anybody. And so I think it would be really interesting to understand how people interpreted that question, because there may be some limitations to what that response looked like.
And just to remind you, it was listed under the category of how would you rate the following COVID-19 related stressors, right? So it was along with childcare and home changes, and so it wasn't in the context of what's your hospital doing, right? It came in the questions in terms of just overall. So I think my interpretation is that global perspective of the news, nonstop news and information.
That really depends upon how many hospitals you're covering, because you have to remember a lot of vascular surgeons cover more than one place. We cover 5. And so if you type town hall as a search into my email, that email is going to freeze, because I have hundreds and hundreds of town hall notices in every hospital, including on top of that, the medical school, the medical system. Everybody's got town halls going. So if you work at Ochsner and you have a single institution, I bet you it's a different story of one message versus if you're me and I've got the Children's Hospital telling me one thing, Tulane telling me something else, LSU, University, the VA. And so for some of us, it is very overwhelming.
Let me ask Dawn and Shireen, for example, did you notice differences in the gender-related issues between the European survey results and the US and your survey results? Perka said that he didn't think childcare didn't score that heavily on his survey. And I must admit, since I'm distracted doing other things in these town halls, I wasn't able to fully study all of the charts and pictures, but I heard him say that. So, are there different issues for women in the States than there are in the European countries?
So the way we asked the question about childcare is we gave people the option to say, does it apply to you or doesn't apply, so that we can just focus only on the women who are affected by childcare. And that was a mixed bag between men and women who felt childcare was an issue. So it wasn't, and we were not intending to look specifically at gender differences, but I will say that, again, the women reported higher levels of anxiety. So that was definitely significant.
All right, maybe our blue sky production people can switch us over to the audience Q&A. We've got a couple of questions. Sam, I'll let you take this.
So some of our colleagues that need help the most are the ones who are not connecting to social media. So how can we reach out to them? I think Dawn and Mal, you probably should start with this, and then we can go to Shireen and see where we can go from there. Dawn, Mal?
Yeah, thanks. That's a really important question. And I'll just highlight specifically some of the early efforts that followed the evolving crisis. And some of this was highlighted on a wellness webinar that we hosted last night with the Surgeon Masters, of which we had Max Wohlauer and Nick Mawad working alongside our coaches to kind of explore this area specifically. I do think that there are many peers and colleagues that we're not reaching through this task force, specifically through this town hall platform and through SVS Connect. And I think that as we continue to move our work forward as a group committed to the collective wellness of our workforce, which has major ramifications for recruitment and retention, I think it's important to be very cognizant of that, and also be very intentional with how we're trying to outreach. And so some of our ongoing discussions and strategy with our next steps as a group really take this into consideration. And you saw a lot of peer support opportunities grow very organically, but they probably also are not fully inclusive. And so I really think it's just a matter of making sure that we have a large body of advocates or champions that can really disseminate themselves and insert themselves into as many spaces as possible. I think the more stewards we have for change, and the more intentional we are with outreach and explore things that maybe are a little bit less conventional, I think that will extend the message and reach as many of our workforce as we can. And I think that's so important.
Mal, do you have something to add to what Don said?
Well, that's, the clear message to people is, yeah, maybe you don't want peer support or feel like you need it, but if we can train as many people as possible to be at least adept at delivering peer support, that's how we permeate these places. Part of the burnout system is kind of isolation. And so social media, town halls, emails, all these traditional ways we have to get people might not be effective, but if we can get people on the ground who are at least adept or competent at peer support, then we can make a difference with the groups that are hard to reach.
Great. I just have to give full disclosure. Max is the person who spearheaded the WhatsApp app. And if I remember correctly, Shireen, that was about half of our people felt they were connecting through WhatsApp, and it was great just reading it at night after getting home and just sort of putting it together. So Max, we thank you for that. The next question says, how can we help support our trainees? Well, there's going to be a discussion on this, and I think that question is probably best answered after Mal talks to us. So what I'm going to do now is I'm going to ask us to move on to Dawn Coleman, who was introduced before, and she is an associate professor. She is a named associate research professor at the University of Michigan, and she also spearheads with Mal I got Mal. I'd rather have Dawn right now, I think. Spearheads the wellness task force for the SVS, and they're doing a great job. So if I can ask Dawn to open up her slides. Dawn, thank you very much in advance. Dawn, you're muted.
All right, can you hear me?
We hear you now. Thank you so much.
I'm so sorry about that. So thank you, Dr. Money, for the introduction, and Dr. Hodgson for putting this town hall together. It's an important theme now, perhaps more than ever, and I'll start by suggesting that this presentation today is not meant to provide any answers or solutions, but rather I'm hoping to start a conversation regarding the longer-term implications that will follow in the wake of this pandemic, that I think are going to probably further threaten our workforce as we continue to transition to what's becoming a new normal. Early on in March, while we were strategizing a field hospital for the COVID surge in Ann Arbor, Dr. Hodgson, you convened a similar town hall that explored wellness implications of the pandemic. And at that time, discussions seemed a lot easier for me to reconcile. There were themes around wellness and leadership during crisis, resiliency, peer support, grace, courage, communication. And now we find ourselves or at least I do, in an increasingly unfamiliar space and a place where there is a lot of uncertainty, a loss of control, this need to transition but not knowing what the ultimate endpoint looks like. And a different strategy is now required that considers not a response to crisis, but sustainability. And so our task force convened in 2017. We have a very engaged membership that I'll highlight at the end, working full-time for our SVS members. Our work pre-COVID has attempted to enhance vascular surgeon wellness in an effort to avoid the personal and professional ramifications that accompany burnout. Existing data, as Dr. Money has already shown, would suggest that we as vascular surgeons are at higher risk than other specialties. And we recognize the growing limitations to our workforce. It's important that we proactively address this uncomfortable space, that we destigmatize a culture of complacent suffering, the hardship Olympics, if you will, and rather optimize vascular surgeon recruitment and retention. We have been listening to all of you very carefully, and we've been prioritizing our responses, but we now find ourselves at a transition point with a need to pivot rather urgently. So this work is important. Your voice is important. And so my objective today is really to share a little bit, but also to listen. And I can't personally see the chat, but I'm hoping that it comes. And your comments will be captured and they'll be really invaluable to help direct our task force and our societal response to member needs. So thank you all for joining today. I'd also like to start by reminding everybody of the business case for wellness. And I think now more than ever, this is extremely important. And evidence would indicate that burnout is a major driver of physician turnover, and multiple large national studies of US physicians have indicated that burnout is one of the largest factors determining whether or not physicians intend to leave their current positions over the next 24 months. And as an example, a 2014 survey of American physicians revealed that 1 in 5 US physicians intend to reduce clinical work hours in the next year, and 1 in 50 intend to leave medicine altogether in the next 2 years to pursue a different career. Now, turnover results in both direct costs associated with recruitment, as well as lost revenue during recruitment, onboarding, and the time that it takes a new physician to reach optimal efficiency in a new system. Historical studies would suggest that the cost to replace a physician is 2 to 3 times the physician's annual salary, and the lost revenue associated with replacing procedurally based subspecialty physicians like us is likely to be substantially higher. Moreover, such costs are anticipated to increase as the physician shortage in many specialties intensifies and replacing a physician becomes more difficult. Now, these direct costs of turnover don't take into account the disruptive impact of turnover on patients, other members of the care team that have to step up in the absence of that lost physician, and the organization's culture and reputation, as studies demonstrate that the turnover of any member of the care team increases the risk of burnout among all other members of the care team during that next 12 months. Now, perhaps the largest financial impact of physician burnout for a healthcare organization is not likely due to its effect on turnover, but rather on physician productivity. And this dimension is a little more difficult to fully quantify, but it is believed that due to the high fixed costs of many healthcare organizations, even a small change, 1 to 2% in productivity, can have large effects on an organization's bottom line. And in academic spaces, burnout is estimated to reduce a faculty member's productivity by approximately 15%. So I pose to you that beyond our moral and ethical obligation to each other and our patients, that there is a business case that hospital administration should be paying attention to that will address physician burnout. It's multifaceted, and it includes costs associated with turnover, lost revenue associated with decreased productivity, as well as financial risk and threats to the organization's long-term viability due to the relationship between burnout, lower quality of care, decreased patient satisfaction, and problems with patient safety. Now, Dr. Money has already reviewed our recent survey data, which was presented at VAN last year and is provisionally accepted to SVS presently. But I want to just remind everybody that about 40% of our respondents in the SVS met criteria for burnout when they were surveyed, and multivariate analysis revealed age, work-related physical pain, and conflict between work and personal responsibilities as independent risk factors for burnout. We identified risks for depression, and we identified risks for suicidal ideation. Now, I will propose that beyond the stress and bereavement and anxiety and moral distress that we might feel during this human crisis, our vascular surgeons now will be further challenged by these known risks that may be compounded during this transition, this evolving new normal, if you will. And I'd like to present this idea to you from the lens that I'm most familiar with, and that's my own personal experience here in Ann Arbor. And so, as many of you are aware, Southeast Michigan was a COVID epicenter. And in March, in an effort to effectively combat the surge of COVID cases, complete restructuring of healthcare was required to prepare for the predicted clinical volume and this emerging human crisis that we were so quickly confronted with. And our surgeons quickly flexed from providing routine vascular care to a short week of providing these scenario A cases of emergent and urgent cases. And then we had this very sustained period of time through late April where we were really only providing emergent cases to preserve life and limb. And this was in direct response to resource scarcity that was resulting from a significant inpatient critical care COVID census. Now at the University of Michigan, from the time shelter at home order was placed until the peak, the COVID-19 cases increased 1,272%, and we had up to 230 inpatient cases requiring ICU capacity. Now this required substantial conversion of existing space into ICU beds, and this figure highlights how we strategized and implemented space for the COVID surge. Specifically, we increased our ICU capacity from a baseline of 99 beds to more than 250 across pre-existing moderate care units, PACU units, and full floors of the cardiovascular and the children's hospitals. And this also then required a significant redeployment of faculty and house officers to staff these units. Our nurses, our APPs, our respiratory therapists, everybody was playing a different role in response to this crisis. And our team responded. Now, additionally, we strategized a field hospital to provide moderate and low acuity care to COVID positive patients off the Hill in an effort to decompress the main hospitals for this critical care effort. And this was a major leadership effort that fell onto a hospital strategic team and then a clinical leadership team that was made up of nurses and surgeons with backgrounds in military service and disaster medicine response. We also engaged FEMA and the U.S. Army Corps of Engineers, and a staffing model was developed that employed the collective strengths and the support of our entire Michigan medicine team. Now, gratefully, we didn't need to operationalize this hospital, and it was officially stood down at the end of April, but it was a really big deal, and it was an overwhelming response. And at least for me personally, it was a really formative experience. Now, with all of that, you can imagine that we lost a lot of money, and we are still losing a lot of money. And we still have stay-at-home orders in Michigan, although there is a very slow movement now towards reopening. And last week, we were permitted finally to schedule again elective cases. And so we're starting to work through our backlog. But the patients are still afraid to come. And the work feels harder than it did before. And specifically, it feels a heck of a lot more inefficient. Now, our hospital leadership in response to this loss has implemented now the second phase of what I presume is a tiered economic recovery plan. And I'm sharing information that's widely available for full transparency with the website reference below. But the goal of this recovery plan is to minimize the impact on our Michigan people, the people that really stepped up during that crisis, and to immediately reduce expenses to ensure that our resources are properly aligned and utilized to support our faculty, our staff, and our learners, and also to preserve the world-class missions that the University of Michigan stands for, the foundation of who we are, clinical care, but also research and education, while simultaneously providing the best and safest care to our patients and their families. So it's projected that we are going to lose $230 million by fiscal year end. We've already worked towards a workforce reduction that includes 1,400 FTEs. This is through a combination of both furloughs and RIFs. We've seen salary cuts, suspension of the university contribution for retirement plans, a hiring freeze right now that feels a little bit indefinite. And I say reduced, but it's a near cessation of discretionary spending, even in the form of philanthropic gift accounts and professorships. We'll have no ability to offset travel expenses, recruitment expenses, hosting expenses, professional development. And so this is our new norm for the foreseeable academic year. And this is a really dramatic change, especially at this institution. And I would suggest that I can't imagine that we are alone in this. The shutdown of elective surgeries and other non-essential medical care by federal and state officials during the pandemic has left the nation's 5,200 hospitals, particularly in places where there have been relatively few infections, with idle clinics and vacant operating rooms, a dearth of patients. And while health jobs typically grow in recessions, this also doesn't seem to be the case during this specific pandemic. Moreover, healthcare is currently contributing to economic calamity. And this is in part due to the intensive and costly care required for COVID patients that considers PPE needs, staffing, and other critical care resources. But importantly, there's been a near cessation, as I referenced, of ambulatory care, high margin discretionary and elective procedures, and an increase in lower income patients resulting from rising unemployment that is now plaguing the country. Now, the April jobs report began to reveal the impact of the COVID-19 pandemic on employment. And at that time, more than 700,000 jobs had been lost since February. But the world has changed, even in the interim weeks, since these data were collected, and the end of the story is not yet in sight. And this chart illustrates the loss of 43,000 healthcare jobs just in the first month of the COVID-19 economic downturn. And it's unlike anything that we've seen at the start of a recession in the past 3 decades. Now, the most recent news release from the Bureau of Labor Statistics supports a loss of 1.4 million healthcare jobs and a rise of unemployment rates to 10.9% in the sector of education and health services, and that breakdown is shown here. And clearly, COVID-19 has revealed vulnerabilities in the business model of the American healthcare system. The disruption to hospital operations may ultimately leave Americans with less access to medical care, especially as struggling hospitals may close or shut down unprofitable departments, and others may merge with nearby competitors. So while healthcare has always been viewed as recession-proof, it may not be pandemic-proof. And so this is really important. This is important for us as a workforce because we were already feeling threats, and I sense that this is going to become a progressive burden for our team. So what now? How do we optimize and ensure wellness of our global workforce during this challenging transition? And it's important for organizations and leadership to understand the factors that drive burnout and engagement, which can be organized into 7 driver dimensions: workload, efficiency, flexibility and/or control, culture and values, work-life integration, community at work, and meaning at work. And organizations can often make profound and effective changes in several of these dimensions, but commitment from executive leadership is prerequisite, assessment the first step, and the frontline leadership becomes a force multiplier. So I want to move from there and just simply pose to all of you a few questions, and I'd love discussion to ensue, but this is where we're going next. And where we go next depends on what we perceive our needs to be, because again, I don't have any of the answers, and I'm not a wellness expert. I might be the pot calling the kettle black, but I'd ask you now, and if we consider again our pre-COVID data and the drivers that we were feeling at that time that may be compounded, how do we now do more with less? We're being asked to ramp up clinical activity more than ever, see expanded telemedicine clinics that feel increasingly inefficient. We're working after hours and offering elective weekend cases with less support staff and perhaps less house officer support, and nuanced scheduling and administration changes in managing patient fear with sluggish referrals as we wait for primary care and ambulatory care offices to scale up activity. How do we, in an era of ever-increasing virtual meetings, loss of block time perhaps, unpredictable OR and clinic schedules, you just don't know what you're going to see when you come in for the day. How do we set boundaries for ourselves, both personally and professionally? How do we now compartmentalize during this time and regain some semblance of control over our schedules and our lives while still being flexible enough to pivot and shift with those evolving needs? How do we optimize local and systemic culture at a higher level? Importantly, how do you, if this is applicable, reconcile the early value of frontline workers with the now progressive transition, what seems to feel like devaluation, with pay cuts, furloughs, rifts, the loss of people we work with regularly that hurts, it doesn't feel good, And now this push for a clinical ramp up to be done without the same support we once had. How do we maintain a semblance of work-life balance with homeschooling children that are grieving their own losses of friends and extended family and altered routines and canceled family vacations? My 8-year-old is going to want to go to summer school or to summer camp and fish. And the fact that he can't do that is going to just level his little 8-year-old mind. How do we continue to support each other? Not just peer support in response to crisis, but also help network professionally. How do we mentor and sponsor and lift up our trainees and recruits so that we can continue to grow leaders in vascular surgery and maintain a focus on what brings meaning to each of us every day? How do we continue to prioritize the research and the educational pillars that some of us value so tremendously? Now, each of us are experiencing this pandemic and its evolving threats individually. And this experience, our emotions and our responses may change daily and by the moment. They have, at least for me. We're all trying to preserve many things during this time, not just personally, but also our research efforts, our educational efforts, our clinical practice. We are all in this together. So please know that we see you. And I know times are troubled, but we are collectively strong, smart, resilient, and committed to comprehensive vascular care of our patients, our trainees, and to each other. I am convinced now more than ever. So please take the necessary time to take care of yourself, take care of each other, and please share with us, our task force, ideas and opportunities that we can push forward to help you. So thank you all for listening and for sharing today. I look forward to your comments. I want to thank specifically Ken Slaw, Angela Taylor, and Maura Doherty, who have been working tirelessly behind the scenes. There's a lot for them to manage, alongside my co-chair, Mal Shahan, and this amazing group of task force membership. We've been going at this now for several years. We're going to pivot and flex and work towards whatever we need to build a sustainable support program with this new normal. So please share with us your feedback. And again, thank you so much for this opportunity.
Dawn, thank you very much. That was a great talk. I'm certain there'll be a whole host of questions. While we're waiting for the panel to come up with some questions, you know, a lot of people think we're through this, and looking at your data and what you presented, we're not through this. And if there's a rebound, then we're in it again. And more than that, the data you showed just echoes what I'm seeing and hearing about here, is that the hospitals are not going to make as much money as they did. And a majority of the hospitals are plus or minus 4% on their revenue in terms of margin. So with the increased amount of lower paying patients and the fact that a lot of people who need semi-elective hips, joints, profitable operations are being delayed, what's going to happen long term? Where are we going to go? We're going to have to practice in a totally new way.
I think we're going to have to do a lot of things in a totally new way. I think until, and I say until because I do think things will shift dramatically when there is more effective treatment, there is a vaccine, and there's herd immunity if that ever happens. I do think that life and the landscape across our country will be different now in a very sustained fashion. And things that we thought in March were going to be transient with kind of those best practices lingering, I think we're facing a whole new norm for healthcare. I don't know what that looks like yet, but I do think that it means we are going to have a sustained state of doing more for less. I think we're going to see a dramatic reduction in some of the perks I think we all really appreciated and enjoyed. And my hope is that we will all respond, and I don't mean just us as vascular surgeons or healthcare providers generically, but higher systemic level oversight bodies and those who have control to influence the climate of healthcare. I hope that everybody responds in a way that is not short-sighted, that keeps the patient and our future workforce, the rising students and the recruits and the trainees at the forefront, so we don't find ourselves in a much more challenging landscape down the road where we're not able to provide care to our populace.
Dawn, I'm curious, if you don't mind me asking a question here. You spoke about your field hospital that you did up at University of Michigan, and we know that they did that in New York as well. Did you have a pandemic plan that was all set out ahead of time that you just followed, or did you just have to invent this as it happened?
It's a great question. So we did not have a pandemic plan, but we had an emergency response plan. So it was one of those things where I got an email from somebody's name I didn't recognize asking me to join this team to create a field hospital. And John Eliason's name was on the email as well. For those of you who don't know my partner, John Eliason, he's an incredible human being and I would follow him into battle any day. And so I thought, if John's on this team, I want to be on this team. We joined this team with the support of the University of Michigan, not the medical center, but the University of Michigan's disaster response team. And we incorporated features and used some of their infrastructure to build out this plan. But it also rested very heavily on the collaboration that came from FEMA and from the Army Corps. And these were groups that were also helping to navigate the many pop-up field hospitals that were being built across the country. So we were one of many sites.
Great. Dawn, thank you so much. I appreciate this. Was a great talk. I think it's time to move on. I'd like to introduce Mal Sheehan. Mal is the Craighead Professor and Chair of Vascular Surgery at my crosstown rival here, the Louisiana State University. It's great to have a colleague across town who you like and respect as much as I do for Mal. And Mal's going to talk to us a little bit about the workforce issues, training, residents. So Mal, before I waste too much time introducing you, can I turn the podium over to you?
Here we go. All right. I guess I wish this talk were a little more optimistic now that we're coming in the end, but we'll see what I can do. I think it's a great thing that we're introducing is to make your disclosures inclusive of other roles you play in other societies. So mine are up here now. I work with the Vascular Surgery Board, the APDBS, and vascular specialist. Despite these positions, though, I've been relatively unsuccessful in becoming a shill for industry, so I unfortunately have no financial disclosures. So the story I want to tell dates back to the early 2000s. And around that time, the American Heart Association started to notice a decrease in the number of coronary interventions, specifically percutaneous interventions and diagnostic catheterizations. And this followed a trend of decreased number of CABGs as well. And they felt like this was probably due to better medical therapy, more use of antiplatelets, more use of statins. So I guess coincidentally, after this decrease, we suddenly saw a surge in lower extremity interventions. So around 5 years later, the numbers for billing for lower extremity interventions started going through the roof, and Medicare did some investigations and found a few outliers. But who was doing all of these interventions? And the answer was probably not us. These are a little bit old numbers. We don't have really good survey data on vascular surgeons. There's probably about 3,700 in the US right now, but about the time this was all going on, it was just over 3,000. So that's one vascular surgeon for every 100,000 people in the US, one for every 350 dialysis patients, and one for every 2,600 PAD patients. So we're underrepresented in the US. So it wasn't us who was responsible for this surge in lower extremity interventions. And if you look at this time period between 2008, 2013, you see we had a relatively modest increase in a number of vascular surgeons. But these two other specialties who we used to outnumber by a great bit, interventional radiology and interventional cardiology, started to surge in their numbers. So at the same time that their case volumes were going down, their workforces were nearly doubling. And again, this is the same time period, 2008 to 2013. And you see, this is all medical and surgical subspecialties. And the two at the very top are interventional cardiology and interventional radiology. So huge increases for these two formerly small specialties. Another problem we had as vascular surgeons is we were old. 40% of us were over 55, and that becomes a problem when we reach retirement age. Whereas because of this surge in numbers, IR and interventional cardiology were relatively young. So what do we need? A lot of time and effort has been spent by the AAMC and others on figuring out what the shortage is going to be. And wherever the numbers fall, it seems that the surgical specialties are going to be hit the hardest. So if you look at this projected change in physician supply, medical, surgical, other, you see we actually have a decrease predicted in the relative number of workforce candidates, and that's because of reduced hours and early retirements. So there's no model right now where the number of surgeons will meet demand in 2030, and we're kind of getting further and further from that. So more recently, this is the next 5-year period, 2012 to 2017, and you see there is no change in these trends. Here is interventional cardiology, here is interventional radiology. So tremendous increases again in the next 5-year period for those two. And so what about the future? Well, we can look at how many trainees they have. And here you see a huge number, again, right at the top, interventional radiology. And this is before the integrated interventional radiology program. So there is no possible way we're not going to have too many interventional radiologists in this country coming up very soon. So why is this going to be a problem? This is us, that's vascular surgery. So we've made some modest increases intentionally in our number of trainees to try to improve our workforce, but you can see we're dwarfed by some of our colleagues. So why is this a problem? Because nature abhors a vacuum, right? Or as they told us in Jurassic Park, life finds a way. So there are major areas in this country where there are no vascular surgeons. I can tell you there was a major medical institution in New Orleans without a vascular surgeon for several years. And people just find a way around it, and cardiology and radiologists, who I've shown you are plentiful, will find a way to occupy these voids. So it's an existential crisis, and one we have to face throughout the country. Now here's somewhere where we're winning. We actually do a much better job of recruiting women into our field than interventional cardiology or interventional radiology. Now I wonder what will happen to these numbers as the integrated interventional radiology programs begin to expand, and we'll see what happens with that. But for now, this is something we're winning, and we should actually try to increase our efforts in this field. So just locally, how are we doing with the integrated positions? So the last 3 years, the numbers in orange are the numbers of integrated vascular residency positions we're offering in this country. And you can see we've had a nice increase from 60 to 75 positions each year offered. But the problem is we're not doing a good enough job of getting our US medical students to apply to vascular surgery. And if we look at the numbers since the integrated program began, the number of applicants kind of hovers around the number of positions. So you can compare that to integrated cardiothoracic surgery, and they've done a good job of getting about twice as many applicants as they have positions. So what about IR? Well, they kill us. So hundreds and hundreds of students apply for relatively few integrated IR positions. So part of that is name recognition, part of that's better branding. They're a bigger field than we are now, but you know, we can look to this as kind of a model for where we need to go. And if you look at the fellowships, that seems to have stagnated. So expanding our workforce is probably not going to come from the fellowships because we're hovering around 118 to 120 positions and filling about 85% to 95% annually. So we seem to have stagnated there. Now we can look at general surgery as kind of a farm system for the fellowships and see there's a problem because about 20% of general surgery residents drop out. And that's affecting females more than males. So I already said females should be one of our targeted groups to recruit, and yet 25% of them are dropping out of general surgery residencies. And most cite uncontrollable lifestyle. So this is where wellness comes in. We have to fix this problem if we're gonna fix our specialty. So I talk about this a lot, is why we do things the way we do. And part of the reason is our hospital system and structure was set up in the early 1900s. And it was done so by people who went through the Great Depression, who fought in World War II. And most of them served in the military. So we have a military system, follow the rules, conform, chain of command. And when these soldiers came back from World War II, the hospital systems they set up were military style, chain of command, absolute authority, hierarchical. And maybe it's time to address that. And I think slowly we have been. This is a picture of Charity Hospital. That's the pit after Katrina. And you can see the surgeon as the god would stand in the middle of this amphitheater, and we all kind of surround him. And that was the system that we had. we're changing it, and it's changing very, very slowly. So the 80-hour work week was actually introduced in New York in 1989, which is a surprise to me because I did a general surgery residency in New York between 1994 and 2000. And I can tell you, I didn't even know this was a thing. So it was introduced, it was law, and it was not enforced until probably almost 10 years later. So because of this, you know, we worked very hard in those days. And I tell my residents all the time, I have a culture gap. Like, I don't know anything that happened in the mid 90s. And I realized this last week. I was trying to write an editorial and I made a reference to Forrest Gump. And then I realized I've never even seen Forrest Gump. So I just have this perception of it. So I had to do a Wikipedia search, find out what actually happened in Forrest Gump to see if what I was saying even made any sense. So that was the old way of doing it. And I think we're moving on. And one of the things I want to highlight is we don't know a lot about trainee wellness. So this group that Shireen and Max and others put together, and this particular survey was led by Adam Johnson, and we looked at what was going on with the trainees, specifically during the COVID-19 pandemic. We got a good response from around the country, and most of the hotspots especially were represented. And just a few things, Adam's gonna submit this to the SVS online, and hopefully we'll see all the data there. But a few things that were interesting is nearly all trainees were affected. So surgeries were canceled in 90% of their programs. About a third of them had to perform as something other than a vascular surgery resident. And nearly all of them had their call schedules changed. So all the trainees were affected in some way, whether in a hotspot or not. But they actually are fairly resilient. And looking at their stress levels, it seems to be fairly low. They're doing a good job coping with these things. And what mechanisms are they using? Well, Shireen explained it scientifically. I'll explain it like a dummy like I am. So active coping strategies, gold star. That's what you want to do. So you want to use these active coping strategies because they're supposed to be more healthy. The avoidant coping strategies are the ones we learned at birth, right? They're very effective short-term and they'll kill you long-term. So denial works, man, but it doesn't work for more than a few days. The argument I have is self-distraction is an avoidant coping, but if the stressor is short-term, self-distraction can work very well. If the stressor is long-term, then self-distraction is going to fail. But so I think our trainees are using very good coping strategies. So this is very hopeful. You know, really, I get accused of using humor too much. So I'll put me there. So let's say that one is good. And then this is how they're reaching out. And as you can see, Zoom get-togethers are very, very popular among our trainees. I am terrible at Zoom. It was all the anxiety in the world. I could get to screen share these slides with you. I'm so happy it came good. I'm wearing a white shirt. I have a white background. I'm very pasty. I don't know what I'm doing with all this stuff. Like, our president is excellent at Zoom, as I've learned over the past several years. Several weeks. But I'm terrible at it. So, but still, this self-support system that we all strive for. I know a lot of vascular surgeons. I know so many vascular surgeons that my phone has identified vascular surgeons as my own children. But I think that we all are reaching out to each other. And I think that's one of the good things that's come of this. And we mentioned Max's WhatsApp group. Again, a way of like-minded people finding peer support. We all know Joe Mills found Twitter, and that's a love match made in heaven. The Facebook groups, the women in vascular surgery particularly got a lot of traction. So again, we're trying to reach out, peer support, and find each other. Audible bleeding, another great resource. Again, an example of vascular surgeons reaching out to each other. SVS Connect, you know, that's the official way that the SVS is reaching out to you. All kinds of people connecting there. I noticed 2 weeks ago, there's a group of people who seem to be connected only in the fact that they don't like to drain hematomas. So that was an awesome group of people finding each other there. I'm pretty sure they couldn't have found each other any other way. So what do we do? So I think the answers are going to come, and Dawn is leading this project for vascular surgery. So general surgery has already done what's called the second trial. And this is basically, we're introducing some wellness initiatives in a controlled manner and trying to see if this makes any difference to residents. So there's a wellness assessment of the trainees before and after these different interventions are done, and we'll see how we can improve them. And the early results are kind of frightening. This is general surgery residents. About 40% are burned out, but you can see the problems. There's feelings of gender discrimination, racial discrimination, verbal abuse, sexual harassment. Again, that kind of automatic authority figure in residencies it permeates in bullying. And this results in burnout and dropout, and especially prevalent in women. So what can we do? These are some of the sample things that are happening in the second trial. So Emory's going to have a half-week day off per month. Stanford's going to do high-performance team training. Wisconsin has lactation going. So just different ways that we can assess what we need to do to help our trainees. Again, because the data right now is really lacking. So if you look at what they want, they really want you to be on their side. So call them by name. You know, duty hours, case logs, EMR, all this paperwork, it sucks, right? So you have to tell them, yes, I know, I don't want to fill out the duty hours either, but we have to do it. We're in this together. So it can be as simple as parking. You know, parking can be a stressor. The meals can be a stressor. You know, wellness days, like we said, they can't get to the DMV. They can't get to the notary. You know, little things that we can do might make a big difference. But I say this all the time. I get up and give a talk about wellness, and invariably some administrator gets up and says, I have $50,000 grant and I can, you know, put this towards wellness, and what should I do? I say, I have no idea what you should do. You know, this is a local thing. This is all politics are local, and burnout is local too. And what you as an administrator, or you as a program director, or you as a mentor need to do is talk to these people and figure out where the gaps are and what we can do to make this better. You know, the SVS, probably the #1 specialty society of addressing this, but it's still gonna be local. And so there's only so much we can do nationally, but we need local support as well. And that's kind of up to all of us. So finally, you know, all the time people are like, well, how can you get up there and say we need to recruit more people, but then you're telling everybody how much burnout we have? And I don't know, it's like, you know, I guess it's a commentary and a duality of man, right? So that's at least a reference that I remember. But this is important. If we don't fix this problem amongst our trainees, we're gonna have an even worse workforce shortage. And, you know, and really, like I said, it's an existential threat for us as vascular surgeons. So I think it's something we all need to address. Thank you.
Mal, thank you very much. I'm certain there'll be a bunch of questions, but before we get to them, I'm gonna pose sort of the big question, and I don't want you just to answer it. I want Dawn to answer it. I'd like our friend from abroad to answer it, and Shireen. So COVID hits, it changes the equation. There's a new normal. Does it affect vascular surgery recruitment going forward? Do we bring in better quality applicants, lesser quality applicants, or no real change?
It's going to affect the process in many, many ways. And the reason is they can't do their sub-Is. Probably we're not going to be able to do in-person interviews. And so to some, this will be a leveling, because I think, you know, different programs have different cultures. So the problem is going to be matching the trainee to the culture of the program is going to be much more difficult through this virtual interaction. And I don't think that right now it's going to affect the number of applicants we have per se, because I think that they're getting their mentorship locally. But I do think it's going to greatly impact the match process, and probably in a very negative way as far as getting the right people to the right institutions.
Okay, Dawn, what do you think?
I always agree with Mal, and so I echo everything that he said. I'll also suggest that, you know, program directors across the country right now are focused on this specific challenge, and our students are super anxious. And I think what's going to happen is that we have to think of innovative ways to engage students external to our home institution, folks that we don't know, engage them so we're still exposed to them, and help them in some different platform understand the nuances of our program in comparison to others. I think it's going to put a lot of extra work on their plate to seek that out. I don't think it's feasible for them to explore every single program with some personal connection outside of maybe exploring a website. So I think there's going to be an expanded online presence for programs. Really important that trainees get that exposure to the candidates and the applicants, and that's going to be a challenge without an active in-person interview. And then I also think that you've got this combined responsibility to those that are considering the specialty and working their way through the interview process and the application process, but also your own internal students. And you're going to be responsible more than ever, perhaps, for letter writing and outreach and networking, even for folks outside the specialty of vascular surgery, when you think about the collective student presence at a single institution. So I think we have a lot of work on our plate. I think it's going to be really different this year. I think there probably will be some best practices that linger because the application process isn't inexpensive, and it's a lot of effort for our trainees. And so I'm anxious to see how that all kind of moves forward, but there are folks thinking about it, I think, at a high level.
So aside from the hurdles, I'm going to rephrase my question. Increased desire to do vascular surgery, decreased desire to do vascular surgery, no effect on vascular surgery.
I think if we can continue exposing our students at our home institution to our specialty, we will continue to grow a healthy workforce because the specialty is really great. And to be fair, it might give us more time with our own trainees to do that. So I don't anticipate we're going to see any change in the quality or caliber of our applicants this year. And I think it's an opportunity for us to perhaps reach out better than ever to preclinical students for future recruitment.
Shireen, your view on this?
I think I'll take the silver lining approach. I will say that increasing use of digital media platforms in the way to communicate has flattened a lot of the hierarchies where people have room to talk and meet and socialize. You saw that the Zoom meetings were popular, whether it's on trainees or by vascular surgeons. For example, I'll give an example. So Gabby Velasquez has started these lecture series for fellows from across the country and has created this opportunity for all the fellows to be in the same room. And this may be a new way of forming new relationships that haven't formed before because they were restricted by geographic patterns or travel patterns. So maybe this is actually a good thing. I mean, we're spending more time at our home institutions. Like Don said, we're spending more time with our own trainees. But also, everybody has now access to a larger community of vascular surgeons than ever before, compared to, for example, the in-person meetings. So if we leverage this correctly, I think you can get more exposure and more recruitment.
Okay.
Sam, I wanted to take exception to something that Mal said a little bit earlier, and that is the concept that we measure the success of our programs by U.S. grads enrolling in them only. I've trained a number of FMGs over the years, and they've been outstanding physicians, and I really think that that's a group that is probably just as much discriminated against as many of the others we hear about. So I don't think you meant it that way, but I just wanted to make that point of clarification.
You're 100% right. I did not mean it that way. It is the best marker of our own ability to recruit, because those are the people we're exposed to. So it's not meant to be any marker of quality. But the fact is, I can't even have an international student rotate with me at LSU at the school policy. So we have almost no, the SVS has been great about getting some of them to the VAM programs. And anybody who's listening who's one should know that there's VAM online programs for the next week that they should be tuning into. But as a marker of a US program's ability to interest students in vascular surgery, that's what we have to use.
Well, maybe it speaks to the fact that we're not doing a good job with our medical students around there.
Yeah.
So while we, Perka sent out a little comment on the chat that I'm going to ask you to expand on. He's questioning whether we have too many vascular surgeons in the United States. Clearly, I guess we've got far more per capita than you do in Finland. Is that what you were trying to say?
No, the other way around. We have about, compared to your figures, you're a 60 times bigger country. So we have about 6,000 vascular surgeons compared to your 3,700 or what it was. So actually, we also have a queue of young trainees to my hospital, but I don't think we have an abundance of queues to other hospitals. So I think you're totally right that the key for us, because for some 10 years ago, there really was no queue to vascular surgery. And now it's like 3 years waiting time before they can come to show their faces to us. So I think the real key is to be in the community very early, and have an attractive program. And I don't know how you're coping with training them to do endovascular and open vascular and everything together, but I think that for us is really a challenge, because when they come out of the pipeline, they should be doing a lot more stuff than just the general surgeon previously. So the training program is really challenging nowadays.
Okay, Kim, do you want to go to some audience questions, or maybe one of the panelists has a question? What would you like?
Let's do the audience Q&A. Well, you've got this one up because it's an open poll. So why don't we take a look at this, because this is what the Wellness Task Force was interested in getting a little bit of feedback on. So we'll take some comments from the task force about these. A lot of people want meaning at work. Does any of this surprise anybody? Anybody want to comment?
Now, the branding and value is something that we know, and Joe Mills is obviously working on. So that's good. I think people want to go to their hospital administrators and be able to negotiate in good faith of the value of a vascular surgeon. I think that's a very prevalent concern for us.
All right. So Sam, why don't you distribute these around?
So, Dawn, you want to read the first one? I think this is something that's kind of you touched on.
Do we think that uncertainty is more stressful than too much information, and how do we help people deal with uncertainty? Yeah, so that's a really great question. This comes from Shipra Arya. I think that when people don't know, people are afraid. So I think the lack of knowledge breeds fear, and I think having some knowledge can be really empowering. Because as Shireen has already referenced with her tools and these active coping skills, we can expand on productive, active coping with a little bit of knowledge to permit us to plan. And so I think that as long as the communication is authentic and it is correct and it is consistent, I think it's really, really important, and I think it's really, really empowering. I think the problem with the information overload is some of what we've already referenced, and so I don't want to belabor that, and I hope that's answered the kind of comment question.
Great. Comments from the other panelists about this?
I was going to add that it's okay for leadership to say we don't know. It's okay to say this is unprecedented. It's okay to say we're learning together with you. That is much better than pretending to know and then giving conflicting information. So that's where that transparency is super important.
That's an excellent comment, Shireen.
I just remember this experiment I read in Psych 101 where they had these rats, and one rat, they would like shock them every 5 minutes, but every 5 minutes on the dot. And then the other one just randomly shocked this guy, and it was the same amount of shocks, but the guy you randomly shocked, he went insane, and the other dude was all right. So that always stuck with me for some reason. I think this is the same thing. We're going to shock you every 5 minutes versus you don't know when we're going to get you.
Well, you may be referring to my internship there, getting shocked regularly. Let's talk about alcoholism and other drugs. And I know some of these are probably underreported, but I know the rate of alcoholism is a little higher in some of the Nordic countries. Rika, do you think that we can get people to start jogging and running rather than having a second or third or fourth cocktail?
I don't know. I think the alcohol monopoly in Helsinki is doing, or in Finland is doing quite well at the moment. I think people are drinking at their homes. I don't know that doctors would be doing it. Amongst vascular and cardiac surgeons, at least in our hospital, the watches are a great thing. The Apple watches, Garmin watches, and Suunto watches, because you can have your program. And I'm actually addicted at the moment, so I'm having a training program through COVID to run faster my half marathon. So sports is one addictive thing, obviously. Many of us are addicted to work, and that's maybe declined a bit. And then we are sitting in front of our screens, and I don't think that's always a good thing.
Yeah, I think screen time has gone up tremendously, and as you said, We're
Focus on
addicted.
Max's question there in the other text to screen.
Right. So we'll get to that in 1 second. But I think that trying to get people to cope with healthier things would be great. But I don't know how you do it with your colleagues. They think that people who exercise every day are probably a little crazy to get up at 5:30 or 6 o'clock in the morning and go for a 5 or 6 or 10 mile run before you go to the hospital, which is probably what you're doing now. And
No, not really. In the evenings, we have a bit more longer evenings. But what they did actually at the COVID intensive care unit, because there was a lot of new people working at the same unit, and we have a 15-floor hospital. So they had this competition running from floor T up 17 floors up to 15, and they took time. So there was a list on so you can do that in hospital as well. It was like professional athlete did it in 1:29, I think, and the average was about 2 minutes.
unbelievable. Let's go to our third question here, and this is from Max. And I think it's truly a great question. With the steady stream of Zoom calls and work from home, what strategies do you have to do work-life balance? Because the Zoom calls have overtaken a lot of what used to be home time. Kim, I think you must specialize in Zoom calls. You probably have more than anyone else on the panel, maybe anyone else in vascular surgery. Is it affecting your life, all these calls?
Well, yes, there's no doubt about it. But by the same token, I don't have much else to do at the moment. I am spending more time, as those of you who were at the trial session know, I have a fair number of birds, and they're spending a lot of time out with me. I put them away for these sessions, so we don't have any interruptions. But it's a challenge, and I think we're seeing a lot of Zoom fatigue. There's no doubt about it. And that's just on these kind of interactive meetings. The real question is going to be, what about the less interactive, more content delivery things like sharing cross? How long are people going to be comfortable sitting in front of a screen? Usually when you're in a lecture hall, you kind of walk in, you walk out, you get a little exercise, you talk to somebody, you do something a little bit different. So Zoom fatigue is going to be a real problem. There's no doubt about it. We're going to have to find the sweet spot for what we can deliver this way and what we just have to be face-to-face to do right. So,
great. Comments from the panel? Well, I think we're basically at 2 hours. So I'd like to thank everybody on the panel. I'd like to thank the audience for sending in some great questions. And I'd like to thank the SVS for putting this all together. Thank you, everybody. This was very informative for me. I hope you all feel the same way. Thank you for your time.
all right, and I'm just going to close here for a second. Want to like to take this opportunity to thank all of our panelists for their contributions to this. I think this has been a wonderful session and a lively discussion, and it's great to hear all the different points of view and how it's been handled internationally as well as around our country. I want to remind everybody, next week's scheduled town hall is a preview of coming attractions about SVS Online, Friday from noon to 2. So with that being said, once again, thank all our panelists. We appreciate your time and input into this, and thank our audience. We'll see you next Friday. Be safe.
Each year, millions of adults in the U.S. are diagnosed with vascular disease. And it's no wonder. With over 60,000 miles of intricate arteries and veins throughout the human body, there are bound to be complications due to blockages, weakening of the blood vessel wall, and other issues impacting the circulatory system. With an aging population and the growing incidence of risk factors such as diabetes, high blood pressure, obesity, smoking, and the disproportionate incidence of vascular disease in our minority populations, the management of vascular health is becoming a key focus among today's healthcare leaders and providers. As with any medical disease or condition, it takes an entire team of dedicated professionals to find new ways to efficiently diagnose and treat patients, as well as to improve their long-term care. In vascular health, the leader of the team is today's vascular surgeon. Only vascular surgeons dedicate their entire training and practice to address the full spectrum of vascular health, as well as provide comprehensive care that includes preventive, medical, surgical, and minimally invasive solutions. Through ongoing education and research, as well as pioneering new techniques, vascular surgeons are on the leading edge of clinical breakthroughs that are transforming vascular health. As part of their comprehensive approach, vascular surgeons partner with other healthcare professionals to provide quality care tailored to each patient. This patient-centered model is vital to help all physicians manage vascular health in at-risk populations and promote healthier lifestyles in the future. Vascular surgeons are involved in every part of the disease process, from making the diagnosis to the management of disease. Vascular surgeons are comprehensive leaders in vascular health. Today's vascular surgeons are creating a new chapter in the vascular health story with improved patient care, better outcomes, collaboration, and leadership. Surgery is only part of our story.